If you think about liver-directed therapies, we can roughly distinguish two approaches. One is for patients that have smaller tumors. In general, tumors shouldn't be larger or bigger than 3 centimeters. In those patients, we can use radiofrequency ablation or microwave ablation nowadays more often, and in the early days, we also used ethanol injection specifically in patients with liver cirrhosis. This is quite effective, but the problem is if you have like small micrometastases around these tumors, these patients are at risk to local recurrence. Therefore, and specifically if the tumors are larger, patients are treated with TACE. TACE is an transarterial chemoembolization. So the basic principle of this treatment option is to do an embolization of the tumor, to cut the vessels, and with that to induce a tumor necrosis. And this works really well in patients that have tumors that are bigger than 3 centimeters. It's not really clear-cut at which point you shouldn't do it anymore, but probably tumors that are bigger than 7, 8 centimeters will not respond in most cases very well to TACE. But there are some patients that still might benefit from it. But in general, tumors shouldn't be too big, and the liver function should be appropriate to use TACE in patients with HCC.
So chemoembolization plays a major role in the management of patients with liver cancer, especially those with liver-confined disease. There's been randomized studies that have confirmed a role for this approach, really in patients who have well-preserved liver function, who have a good performance status, and tumor confined to the liver without significant liver cancer-related symptoms. And importantly, patients who do not have significant involvement of the vasculature of the liver, specifically portal vein invasion or portal vein thrombus. That is an area of controversy, I think, in the setting of patients with managing patients with chemoembolization. There are systemic therapies that have shown to improve survival in that group of patients. Certainly, patients often receive several chemoembolization procedures during their course of management, but once we see that the tumor is growing despite chemoembolization, or that it's transitioned from not invading the vasculature to invading the vasculature, those are all cues that a patient should probably be transitioned to systemic therapy. It's where the data with chemoembolization is lacking, and critical for, I think, the optimal management of all these patients is that they get stage-appropriate management. And if someone develops characteristics of advanced stage disease, it's important that they get an opportunity to receive systemic treatment.
Y19 is increasingly used for the treatment of HCC. One problem we have here is that we do not really have prospective trials that have shown that we can achieve a survival benefit for our patients, and trials that could really indicate in which patient population we should use Y90 therapy. So we do have a lot of retrospective single-center studies that give us an indication that it's feasible and that we probably will not see too much toxicity, so we can use it in patients with HCC, even if they have an underlying liver disease or more advanced liver fibrosis or liver cirrhosis. But as I said, we do not have prospective trials. And this is probably at the moment the main problem we have here, because we have seen a lot of promising phase 2 trials for systemic therapy, and they never really translated in a survival benefit in larger phase 3 trials. So this is something we clearly need. And what we also know is with TACE, for example, that we might induce a deterioration of liver function. The same could happen with Y90. Therefore, the prospective trials are really important. At the moment, most physicians most likely will use Y19 in patients that have a vascular invasion of the portal vein, for example, because in contrast to TACE, we do not do an embolization here, and it's most likely safer than TACE in patients with portal vein infiltration. And in patients that failed TACE, actually, and that are maybe not good candidates for systemic therapy. So after TACE failure, a lot of physicians use Y19 as the next therapeutic option.